I'll be talking about M- uh, MASLD and the role of dual PPAR agonist basically. Now MASLD is the new term. Previously the term was non-alcoholic fatty liver disease, which has been changed to MASLD, metabolic dysfunction associated steatotic liver disease. Now this basically is a disease which is part of the metabolic syndrome, which is the epidemic in today's world. Steatosis is defined as liver fat in excess of 5%. Generally, plain steatosis will not harm the liver, but if it is associated with inflammation, that is steatohepatitis, then the liver injury occurs, and some of these will culminate into liver fibrosis, and some of them will again go for liver cell failure or hepatocellular carcinoma. Now, this steatosis, if it is coupled with a metabolic dysfunction, which may be elevated triglyceride, low HDL, diabetes, pre-diabetes, obesity or high blood pressure, will be extra injurious to liver basically, and what is called as a double hit or triple hit hypothesis. So steatosis combined with metabolic syndrome is basically very, very harmful, and therefore lifestyle modification are core to this management of this problem. Now if you see the prevalence is huge, 25% worldwide, but India leads again with almost 40% incidence of hepatitis, steatohepatitis, the MASLD. Now, most of you must be thinking that obesity may be the cause of steatohepatitis, but it is not so. Even 60% of the normal weight individuals also carry this disease, and this disease is higher in pre-diabetic and diabetics to the tune of almost 80%. So if you see the associated complications with MASLD, you have obesity, you have type 2 diabetes, you have hypertension, you have high triglycerides, you have metabolic syndrome. Now if you see the knowledge, attitude, practice for MASLD, it is very poor, awareness is less, awareness of progression to CVD is also less, recommendations for NFLD management from doctors also poorly communicated to the patients, patient clinic visit after recommendations for NFLD management are also suboptimal. So all of this less awareness basically translates into a non-management of this condition, and this condition is very essential to manage because management of this condition is equivalent to management of metabolic syndrome, all parameters of metabolic syndrome in your patients, and will give a good quality life and a better lifespan, health span to your patients. And therefore, management of this condition, awareness of this condition is very paramount to management of all patients of metabolic syndrome and diabetes in particular. Now, if you see the distribution of HCPs who have and the awareness, you can see that more than 50% are having suboptimal awareness of this condition, and this basically is very, very critical area which needs improvement. Now, what comes first, MASLD or type 2 diabetes? Now, what happens is that even at the stage of insulin resistance, you have a defect at the level of lipid management because the free fatty acids spill over in the circulation. There are excess of free fatty acids. They get to the liver. There is conversion of these livers into diacetylglycerol, DAX basically, which causes fatty liver. Also, the lipid oxidation is also impaired. You have low HDL levels, and the effective functional HDL is also less. The LDL also is more oxidized, more small, more atherogenic, and therefore what we have is a low HDL and a very high triglyceride level, and the triglycerides basically will also damage the HDL and LDL basically, making them more atherogenic, and the HDL scavenging capacity will decrease. The environmental factors, the dietary factors, sedentary lifestyle, add injury, genetic predisposition again leads to injury to the liver, and these patients, many of these patients will go on to develop inflammation of the liver, that is steatohepatitis, end-stage renal disease or hepatocellular carcinoma, all of this being eminently preventable by proper lifestyle management and certain medications which we will discuss. Now, if you see the MASLD in diabetes in India, high prevalence of steatosis and fibrosis is present in patients. The fat deposition is measured as S0, S1, S2, S3, and the fibrosis is measured as F1, F2, F3, F4. Your major emphasis should be prevention of stages of F3 to F4, because that will be a late stage of fibrosis. If you see the prevalence of clinically severe liver fibrosis in FLD patients with type 2 diabetes, you can say that 58.9% of patients have steatosis. Of this, 22.7% have significant liver fibrosis. These are the studies from India. Basically, we have higher BMI, higher AST, ALT values, as well as lower platelet counts, and they are associated with clinically significant liver fibrosis. The elevated AST, ALT we cannot rely upon because they are present only in 27% patients and 37% individuals with clinically significant liver fibrosis. But SGPT, SGOT ratio is very important. If the SGPT, SGOT ratio is equaling 1, or if the SGOT is going beyond SGPT, you should be very, very suspicious for advanced liver disease in your patients. This study highlights the importance of screening for liver fibrosis in type 2 diabetes patients, irrespective of transaminase levels. So, like ECG, like echo, the screening of liver also should be made a very, very compulsory part of your examination of patients of diabetes, obesity, and metabolic syndrome. In type 2 diabetes patients, the progression of NAFLD to cirrhosis and relative mortality is higher. You can see these two groups. One group is without diabetes, one group is with diabetes. You can see that more patients in the diabetic group will have non-alcoholic fatty liver disease, more of steatohepatitis, more will be progressing to fibrosis, to cirrhosis, to hepatocellular carcinoma, and more will be requiring liver transplant. And therefore, diabetic patients in particular should be periodically screened for this condition because they are very high risk. Now, the patients who have MASLD are having inherent insulin resistance, hyperglycemia, oxidative stress, systemic vascular inflammation, endothelial dysfunction, genetic phenotype also predisposes to the CVD complications, atherogenic dyslipidemia, coagulopathy, dysbiosis of the gut microbiota, which leads to more incidence of ischemic stroke, peripheral artery disease, chronic kidney disease, and coronary artery disease. The fat in the liver also correlates with the epicardial fat, which leads to excess incidence of heart failure, especially the heart failure with preserved ejection fraction, also translating into more chances of atrial fibrillation and recurrence of atrial fibrillation after ablation and bradytachyarrhythmias. All of this predispose these patients of MASLD to excess CVD risk, excess CVD morbidity and mortality. If you see the clinical association of CVD and CKD in patients with MASLD, you can see the risk of MACE is very high, peripheral artery disease, ischemic stroke, cardiac arrest, CKD, MI, CAD, atrial fibrillation, and bradyarrhythmia, all are much higher in patients with MASLD, and this basically again emphasizes the fact this condition has to be managed, and the management has to be similar to the patients of diabetes, not glucocentric. You have to manage all the risk factors which are involved basically if you are to improve the prognosis in your patients of MASLD. So the EASL, ESD, EASO clinical practice guidelines now recognize this condition. There is a great emphasis on this condition, great emphasis on management of metabolic dysfunction associated with liver disease, and this starts with early screening of these patients, and all of these organizations will advise early screening of MASLD, management of all the risk factors which lead to these conditions, and FIB-4 score is routinely advised to classify your patient as per the risk criteria. Now, FIB-4 is a very simple test which takes into account age, AST, ALT into consideration, and basically the issue with FIB-4 is that it is standardized for age group of 35 to 65 for younger populations, because this condition is also seen in younger population. You have to be very proactive, you have to suspect metabolic syndrome in your patient, even younger patients, and you have to basically screen them for liver fat and for impending liver fibrosis. In the patients above 65, this FIB-4 score basically requires modifications which are beyond the scope of this talk. But 35 to 65, this is a very standard test. Less than 1.3 effectively rules out a significant liver disease. 1.3 to 2.65, you have to basically use an alternative test or screen them periodically. More than 2.67 is very suspicious for clinical significant liver disease. So the test which is more rampantly used is VCTs, that is vibration control transient elastography. So FIB-4 score is more for exclusion of clinically significant liver disease. In a intermediate range or in a higher score, you have to go for further tests to screen these conditions, and these tests are VCTE, which is the most affordable and most practical to use. MRI is the gold standard basically, especially the studies of MRI which quantify the fat and the liver fibrosis, and liver biopsy the gold standard, but because it is an invasive test, more emphasis is being used to MRI for research purposes. So FIB score is directly proportional to CV events, all-cause mortality and liver ends. You can see, depending on the FIB score, as the FIB score increases, you have more cumulative liver events, more cumulative cardiovascular events, and more cumulative all-cause mortality. So the vibration control transient elastography is the test. The liver stiffness is measured with LSM less than 6 is good, 6 to 8 you have to be suspicious for stage 1 liver fibrosis, and more than 8 is basically you should strongly suspect liver fibrosis. The CAP basically is the test for knowing the liver fat. Less than 260 is normal, 260 to 280 is excess fat, and more than 280 is significantly excess fat. Now, what is the difference between FibroScan and VCTE? The FibroScan is a patented technology using this modality, and therefore, because it is a patent technology, you have to pay excess. But now, with modifications of the higher end ultrasound machines, you can do VCTE and measure the liver fibrosis, and the function is almost similar to FibroScan. Coming to the role of Saroglitazar in the management of MASLD. Now, MASLD management, the basic core management is lifestyle modification, which is diet control and weight reduction. You have to manage all the comorbid conditions like obesity, type 2 diabetes, and all the individual components of metabolic syndrome and bariatric surgery. So weight loss, anything more than 5% gives metabolic improvement, more than 7% decrease in the liver fat, and more than 10% you can land up with even decrease in the liver fibrosis. So you should aim for a weight loss of excess of 10% if you are to reverse the liver fibrosis. Majority of the drugs are not practical. Vitamin E is a very commonly used drug, but its efficacy is more in non-diabetic patients compared to diabetic patients. DCA and obeticholic acid have not proved their efficacy and are not approved. Saroglitazar, which was initially approved for atherogenic diabetic dyslipidemia, is now approved basically for MASLD, the first drug to be approved in India for MASLD management. It has dual action. The PPAR is basically leading to excess oxidation of fatty acids, and you can see with fatty liver, the core pathology is dyslipidemia and infiltration of excess fatty acids in the liver, which is addressed by this drug Saroglitazar. It also decreases significantly the triglyceride levels. PPAR gamma basically increases your adipose tissue and other areas, insulin sensitivity, and leads to reduction in your HbA1c levels. So it causes both elevation in diabetes, elevation in triglyceride levels, and reduction of fat in the liver. Also, it is also shown to reverse the fat. So there are series of studies, that is the evidence study, which have shown effectively that the liver fat reduction to the tune of more than 10% is achieved. The fibrosis regression is also achieved with these studies basically, and these various studies have taken placebo as the comparative arm, and you can see there is a very good reduction in the liver fat, and there is a reduction in the liver fibrosis also. You can see the patient can go from FT to F2 and FT to F1 basically. Easily shown. The only constraint with these studies are the patient numbers are less basically, and therefore the Zydus company, which has discovered this molecule, is doing a large trial in the US basically. Results come out, it is likely to be the first Indian drug to be approved by US FDA for management of MASLD. We have now long-term studies like 96 weeks follow-up, 144 weeks follow-up, and in all of these follow-ups you can see the KPA, that the liver stiffness going down, the liver fat also improving significantly basically, and this drug basically is now the only drug approved for management of MASLD in India basically, and there are several drugs basically which are causing improvement. Pioglitazone was the first drug to shown to reverse the liver fibrosis, but the problem with pioglitazone is that the dose used was 45 milligram, and 45 milligram, using 45 milligram on long-term basis is not viable for our patients. Therefore, this drug is not being rampantly used, and the Saroglitazar is using the same mechanism with the pioglitazone is also using. So, it is better to use, replace pioglitazone with Saroglitazar for management of fatty liver disease. The other drugs which are very, very effectively being tried out are SGLT2 inhibitors, the GLP-1 receptor analogs, and tirzepatide also has shown tremendous data in improvement of fatty liver, and one of these drugs, especially the GLP-1 semaglutide or tirzepatide, are likely to be approved in future for management of MFLD. However, there is a mention of Saroglitazone as the approved drug of MASH in India, which is a great achievement for Zydus, and this is mentioned in the global census recommendations for metabolic dysfunction associated steatotic liver disease and steatohepatitis. So even the National Liver Society also approves Saroglitazar as a treatment for MASLD for a period of 12 months. And now majority of the associations like the Lipid Association of India, RSSDI, INASL, CSI, all of this approve this molecule for management of NFLD. So to conclude, MSLD is a metabolic dysfunction associated steatotic liver disease which is redefined from NFLD. Association of at least one cardiovascular risk factor which is seen with this condition. Screening diagnostic tests like USG, FIB4 and VCT are strongly recommended. Lifestyle modifications and reduction are core to the management of this disease. Drug like Saroglitazar is the only approved medication to treat NFLD with metabolic disorders in India, which can reduce liver enzyme, liver fat and fibrosis score as well. Thank you very much.